Okay, good day, everyone. It's nice to be back together. We are joined now by our colleagues on our webinar who are joining virtually on the second part of a discussion we're having here regarding the development and utilization of national hepatitis elimination profiles. And this is a key opportunity for us at the Coalition for Global Hepatitis Elimination to hear from our partners in the countries that you'll be hearing from in a moment about the development of profiles of their plans, policies, programs, and progress toward elimination, and how that process can be improved. As part of this webinar, we want it to be interactive, so please submit your questions as you'll be hearing from the country presentations in the Q&A process. That's on the Zoom at the bottom of the screen. The webinar will be recorded and available on our website at globalhep.org, along with the slide presentations, which is all part of a much larger resource of webinars that we have conducted over the last 3 years. And to stay up to date on webinars that we are hosting, as well as the other activities of the coalition, please sign up to our newsletter while you're there. Just for those that are less aware of the Coalition for Global Hepatitis Elimination is part of the Task Force for Global Health that's headquartered in the Atlanta, Georgia area in the United States. Started about 40 years ago by former directors of the US CDC to address large global health issues. As part of that work, has managed a number of global disease elimination initiatives. And that's why I moved from the US CDC to start the coalition to build on that experience to help us advance progress toward hepatitis elimination, as you'll be hearing from our colleagues in that regard in just a moment. The coalition works in 3 key areas. Next slide. I guess I can do that. We convene partners together to get all the right stakeholders together to have a group approach toward opening access to prevention, care, and treatment for hepatitis B and hepatitis C, be a source of credible information, and be a source of advocacy to mobilize commitments of national governments, as well as other key partners. And I think this profile process that you'll be hearing from is very much in keeping with that. At the end of the day, what we're trying to help everyone is to put together effective hepatitis elimination programs. And the essential components of those programs is represented by this infographic: the importance of good data, the importance of policy development, national commitment, including the commitment of political authorities so that you can get the government fully on board, community awareness of what you're trying to achieve and the importance of it, a focus on health equity to make sure everyone in the country is benefiting from hepatitis elimination, having a financial plan so that the country efforts can be sustained until your goals are achieved, and the importance of what's called operational research so that you're evaluating your program and always searching for ways of improving that program. And I think the profiles really touch on all 3 of those pillars. Brings partners together to build the coalition. It's a source of credible information, as you'll be seeing in a moment. And that information can be used to mobilize greater commitments and bringing more partners to the table. So I'm going to turn it over. So for our agenda that you'll be, for the webinar, you'll be hearing given in a moment from my colleague Lindsay Hebert, who will be giving you a general overview of the National Hepatitis Elimination Profile process. And then you'll be hearing from our colleagues in the countries to bring forward different type of information coming from their profiles, and really gives you a insight into what's going on in these variety of countries. For those that are already here, this is the show and tell part of the program. This morning we've been, as I mentioned, looking at the process of the profiles themselves. Now we're going to be sharing some of the information coming from those profiles. So at this point, I'll turn it over to my colleague, Lindsay.
All right. Hello to those in the room again, and those joining us online. It's a really exciting day for us at the Coalition to really celebrate the National Hepatitis Elimination Profile Initiative. And I'm just going to give you a quick summary of the project for those who this is new to, and then also give you some global trends that we're seeing now that we have 30 profiles available. And so for those in the room, the global trend data will be new from this morning, I promise. So just to start out with, I want to thank again everyone across the world that's contributed to the National Hepatitis Elimination Profiles. It's a really wonderful group, very diverse, of government, clinicians, civil society organizations, researchers, and everyone in between. And we really invite others to join us in strengthening the profiles moving forward. As I mentioned, to date, we've released 30 plus profiles, some very close to release, and about 7 in development stage of some sort. This map here shows you the dark green are those that are complete and available on our website. The ones in orange are in development and near publication, and the ones in green are those that are planned. And originally we set out to develop the profiles for the highest burden countries for hepatitis B and hepatitis C. And so when we look back now, we see that of the top highest burden hepatitis B mortality countries, we've developed profiles for all of them except Russia and the DRC and North Korea. And then when we look at hepatitis C, we've developed profiles for the top 20 mortality countries, with the exception of Germany, France, and again, the DRC. So we hope the profiles are a really strong collection of what is happening with hepatitis elimination in the highest burden countries globally. If you're not familiar, you can find the profiles, the Coalition's website. If you go to the data dashboards tab, there'll be a drop-down link to the National Hepatitis Elimination Profiles. And as a teaser, we'll be updating this part of our website come early next year. Just to set the stage and remind everyone what's in the profiles really aim to bring together data on the epidemiological situation, the program monitoring data, and the policy environment. So the profiles all begin with whether the country has first set an elimination goal, whether they have a national strategy, pulls together the latest data on prevalence information, prevalence in subpopulations, if that's available, incidence and mortality, then looks at progress towards WHO service delivery coverage targets, both the impact targets and the service intervention targets for testing, treatment, prevention, including vaccination, harm reduction, and then combines that with all the policy and environment data that we believe is really unique to the profiles in terms of building out this framework for effective, sustainable hepatitis B and hepatitis C elimination programs long-term, as John mentioned, really building on those essential components. So the policy areas the profiles look at include strategic information, prevention of mother-to-child transmission, access and registration of medicines and tests, testing to diagnose hepatitis B and hepatitis C, access to treatment, financing, and equity. And then the profiles also bring together this data with qualitative information on achievements, innovations, and challenges to really help tell the full story of hepatitis elimination in each country, which is why we're here today to hear from many of our profile contributors. Lastly, each profile ends with a set of next steps, building on those identified challenges and opportunities from within the profile, and really a call to action of a consensus of where partners can work together to help advance progress towards elimination. So now that we have this collection of about 30 profiles for the highest burden countries, the coalition has set out to develop a global report of what we're learning from this initial set of profiles. And that report is forthcoming in 2024. But to give you a sneak peek of what we're starting to see, I wanted to look at 7 policy areas. The first is national planning. The next 3 relate to strategic information, then screening, treatment, and lastly, equity. When we look at national planning, there's been other reviews of how many countries have national plans, but this is really limited to these profile countries. We see that over 70% have established hepatitis B and hepatitis B elimination goals and action plans, and over 80% have established hepatitis C national action plans and elimination goals, so slightly higher for hepatitis C. We also see that for hepatitis C national action plans, quite a few countries have them in development because we're about 10 years out from when the first wave of hepatitis C elimination plans were first established. And so some of those initial plans are now outdated or expired, and countries are hopefully updating them to be most current. When we look at strategic information, starting with tracking incidence and mortality, only about 1/3 of countries have systems to track mortality with national data for hepatitis B and hepatitis C. And for incidence, this is a little higher for hepatitis B, a little over 50%, and hepatitis C about 50% as well. So this is an area for strengthening the policy environment. When we look at prevalence estimates and having recent estimates within the past 5 years, this is a regional snapshot. So of the countries in each region, how many have adopted this policy? And overall, about a little less than 50% of countries have recent prevalence estimates for hepatitis B, and slightly lower for hepatitis C, about 40%. But when we look by region, we see that the Afro and the WIPRO regions have the highest proportion of countries with recent estimates. For the Afro region, we see that many countries have integrated hepatitis B and C prevalence estimates to their HIV surveys. So for example, Nigeria in their most recent HIV survey. And then when in WIPRO, we see there's actually a long tradition of including hepatitis in their national health surveys. For example, for Korea has been looking at prevalence of hepatitis B since 1998 and hepatitis C since 2012. Then the last piece of strategic information I'll highlight here is tracking number of persons diagnosed and treated, which is perhaps the most important part for understanding if you're getting to the elimination goals. And we see only about 1/4 of countries have these systems for hepatitis B, much higher for hepatitis B, but still under 60%. And we learned that many of the challenges for hepatitis data include integration of public and private data systems, and also just being able to leverage the technology appropriately to integrate this into existing systems in place. But we do see some positive innovations. Egypt's massive program was enabled by a large-scale technology platform to be able to track the number of persons treated across their hepatitis centers. In Indonesia, we see that despite not a very large program, that they do have real-time dashboards tracking the number of persons diagnosed and treated. And Mexico, too, has also recently established a national system for tracking the number of persons tested and treated. I also want to note we're both tracking whether the countries say they have these systems in place and whether they actually can report data on the number of persons tested and treated. And we see pretty good match overall. The lowest is with prevalence estimates. Many countries say they have national estimates, recent estimates, but many still defer to using modeled estimates instead of survey estimates. The next area I just want to highlight is screening and 3 key policies. The first being the type of screening recommendations in place in countries. We first look at whether a country has risk-based screening policies, and over 3/4 of countries do have risk-based screening recommendations and national guidelines for hepatitis B and hepatitis C. We also look then, have countries gone beyond risk-based screening to look at either age or birth cohort, or perhaps universal screening, or another screening strategy dependent on their epidemic. For hepatitis B, we see that about a little less than 15% of countries have birth or age cohort strategies, and another about 15% have universal hepatitis B screening strategies. And then for hepatitis C, we see many more countries moving towards universal strategies, which is really exciting as an enabling factor for elimination. When we look at whether patients can access screening, we see that about 50% of NHEP countries have removed cost barriers for patients, not requiring any copays for accessing either anti-HCV rapid testing or hepatitis B surface antigen rapid testing. When we look at access to point-of-care PCR testing, we see that less than half of countries have licensed point-of-care PCR testing in place, despite the availability of gene expert for other diseases such as TB and HIV in many countries. On the treatment side, over 80% or about 80% of countries have established hepatitis B treatment guidelines. Over 90% have established local hepatitis C treatment guidelines, but only about half of countries have removed patient cost barriers and copays. Some highlights from the profiles on treatment access include in Mexico, more than 90% of people with a diagnosis of HIV and hepatitis C co-infection have access to treatment. In Myanmar, there's been a pilot program for free treatment in 8 states, and in Bangladesh has launched a physician training program to expand access, which you'll see. In the profiles, we also look at hepatitis C access in more detail, since there's a wealth of proven strategies to expand access and removal of other patient barriers beyond cost. And we see that these have some of the highest adoption rates across the profile indicators. So there's been great progress in removing fibrosis restrictions in particular, also sobriety restrictions globally, removing genotyping requirements for initiation of treatment, and then slightly less adoption of non-specialists being able to prescribe and simplifying treatment algorithms to not require monthly monitoring and clinic visits during treatment. Some of the innovations we're seeing across profile countries include incorporating telemonitoring and task shifting to expand the number of treatment providers in countries such as Canada, Mexico, the US, Switzerland, and also really interesting dedicated linkage to care initiatives that have improved treatment rates in countries such as Japan, where they have funded hepatitis medical care coordinators to help patients and families navigate the system to access treatment. And the last policy area I'll highlight is really equity, which is really the heart of hepatitis elimination efforts, ensuring everyone has access to care. Some of the innovations we're seeing across countries include integration of hepatitis testing into harm reduction sites, establishing pilot programs for microelimination efforts for most affected populations, and empowering communities and launching national campaigns such as in Spain, the Give Hepatitis C a Happy Ending campaign. When we look at specific policies, the majority of countries do recognize most affected communities in their strategies, which is a big win. But then in terms of actually implementation of policies to expand care, much less adoption. Just for example, only 27% of countries have adopted laws fully to prohibit discrimination based on hepatitis status, and only 45% of NHEP countries have decriminalized the possession of syringes and paraphernalia to enable harm reduction. So with that, I'm gonna stop there and move from the global picture to allow my colleagues in the room to really paint the picture more fully of what's happening in countries and some of the exciting achievements and innovations highlighted in the profiles. Great, I'll go ahead and introduce our first speaker. We're gonna first look at some of the national planning and strategic information achievements and innovations. And our first speaker is from Nigeria, Dr. Ganu Jamayu, who's the viral hepatitis focal point there.
Okay.
Arrow.
Okay. Thank you very much. I feel honored to be here to give a profile of my country regarding viral hepatitis program. So looking at this, on hepatitis B, based on our available data, about 2.8% were diagnosed, out of which only 1% on treatment. As I've said earlier on, everything has to do with out of pocket. Looking at that of C, there is a kind of relative improvement with 3.1% diagnosed and 48% on treatment. Looking at the profile again, from the prevalence of 8.1% for B and 1.1% for C, new infections as estimated in 2022 is over 290,000. And for B and for C is over 27,000. And in terms of HBV related death, it is estimated about 8.4 per 1,000 person. For C, we have 2.9 per 1,000 person. Looking at how we're able to develop the national strategic plan and framework, the journey so far. At the inception, I've said it earlier on, the prevalence is 8.1 for B and C, 1.1%. And we'll talk about issue of awareness. 90% of individuals in Nigeria are unaware, and it has to do with the way the presentation of hepatitis B and C, unlike in HIV, when you see cachectic person, wasted person, and so on. I think those are one of the reasons why our policymakers are not showing interest, because many people tend to be looking healthy. So, our policymaker, if they are not being ginger regarding the presentation, I think those are one of the factors why hepatitis is not being taken serious. Because of the presentation, people are looking a bit healthy. And in terms of the prevalence, where it is actually concentrated is in the north central, northeastern part of Nigeria. And the priority group are people living with HIV, with healthcare providers, men who sleep with men, sex workers, people inject drugs, and also pregnant women, and those who show signs and symptoms of chronic hepatitis B and C. And in terms of the first national strategic plan was developed in 2016, which covered a 5-year period. One of the key things we learned at that time was because there was no baseline data, things were done in line with the WHO document. And because of that, I'm trying to tell about the good aspect of it. Despite the fact that there was no baseline data and so on, we're able to still develop the national strategic plan using the WHO Global strategic document. And in line with that, we're also able to develop an elimination goal in line with that. And also, the document was guided by development of national, led to the development of national treatment guideline policy document and job aids. And following this, the development of the strategic plan, we also activated focal person in all subnationals. And also advocacy toolkit were also developed to create awareness concerning the fact that 90% of people are not aware. And also in line with this, that also encouraged government leadership and coordination of activities. However, some of the bad side of this was because there was no proper knowledge regarding the NSP, because everything was in line with what was at the global level. And also the NSP was not costed. And because of that, there was no actually significant progress regarding that. The NSP was developed with targets, indicator, and development of and implementation of activities were actually without baseline. So everything were done haphazardly. And also the plan was developed instead of the bottom-top approach, it was top-bottom approach. So there was no direction and so on. So one of the things that actually in line with that again, following the expiration of the national strategic plan, we now realized that there was no single achievement. And in order to improve from that, we now had a survey which was conducted in 2019, and that one gave us a baseline, realizing that there was no need for us again to say, okay, instead of the national plan, why can't we have a framework so the other subnationals can develop that plan, and including with national. So because of that, there was a kind of review of a lesson learned from the previous NSP, and realizing that from that review, it was realized that there was limited progress, and a lot of lessons were learned, and the need to shift from top-bottom approach was made. And that actually brought about the need to develop the NSF instead of the NSP. And also data from the NHEPs also contributed in helping to develop the strategy framework. And also there was also review of the new WHO GSS. And also in line with that, there was also consultation by we, which was led by us with other stakeholders, and including a mixed method of desk review, visual consultation, and so on. In line with that, we're able to develop a national strategy framework instead of NSP, so that it gives room for everybody to key in based on their priority area. And to suffice to say, this was eventually launched by the immediate past Honorable Minister of Health in Nigeria. And since then onward, a lot of nationals started developing their national strategy plan for the framework. So the thematic areas for the NSF include issue of harm reduction, issue of diagnosis and treatment, leadership and governance, monitoring and evaluation. We also look at prevention of mother-to-child transmission of BE, also issue of infant vaccination, and also use of blood and injection safety. Some of the key achievements include the having a technical working group, national technical, which I mentioned earlier on. Currently, we now started having that at the subnational. Also, we have national policy on viral hepatitis, which is very soon we need to review that. Also, for the first time, we commemorated the World Hepatitis Day. Subsequently, we're also able to develop our guidelines. Also, we now have what we call hepatitis facility directory, where we can link people to access care. We're able to develop this, realizing in collaboration with ESPA, that is a Society of Gastroenterologists. Also, state activation of state focal person. Also, another, we're able to develop state roadmaps for other subnational. Also, the new guidelines I've said is currently being launched, which are very proud of that. And also, we're also able to report to WHO and the coalition for the first time in line with our achievement. Also, currently we now have, we've been able to launch a visibility study on hepatitis C self-testing, which we just rounded up in November. Also, we have, for the first time, we developed a guideline on integrated HIV and hepatitis we started that for correctional center, but now it has not been expanded to primary and secondary facility. Also, there are a lot of interventions going on and review of documents. As I've said again, part of our achievement is the launching of the EAT project, which is currently being launched by the Honorable Minister. Another aspect which we're able to do with gathering of data, evidence-based evidence from different programs, we're able to key into the current Global Fund round, which is called GC7. And at the moment, PMTC for hepatitis B has been approved, and we are hoping everything will be finalized by tomorrow, being Friday. Also, another aspect is co-infection of HIV, hepatitis C with HIV among part of the co-infection. So that has also been approved for the Global Fund. Also, another aspect is treatment of PWIDs for hepatitis C, which is also being factored into the current grant. So these are some of the, and we're able to achieve it with support, and the support will include the issue of rapid testing, viral load. We are leveraging on the gene experts to be able to provide, to conduct viral load. And also, we'll be using soft dark for hepatitis C, because we are trying to limit the cost because of issue we are not doing genotyping, and so we are using a pan-genotypic drugs, and that is what the countries have agreed upon. And also, other aspects that we are doing right now is the issue of scale of PMTCT, and that will be the issue of hepatitis B will be factored in as part of triple elimination. Also, another aspect of what we are achieving is the harm reduction program, which also we're also leveraging on that. So treatment will be provided at that end. And also, we are currently reviewing a lot of documents, again, apart from the guideline, we're training manuals and others. And also, the other thing we are trying to do is to include HIV drugs into the pool of drugs for HIV drugs. So these are just to tell us some of the data we're able to pull out on viral hepatitis for the country. And also, this is data for harm reduction, which we are also able to get, meaning that we are actually doing a lot regarding harm reduction. So some of the key lessons learned from the African Hepatitis Summit is the fact that we've been able to advocate to subnationals. And one of the key achievements now is that Delta State has factor-free treatment of hepatitis for all pregnant women. That's it. Following that, that's one of the key achievements. And also currently we're engaging with subnational to develop their work plan, which is another achievement we've been able to do. And many states are now trying to, take responsibility for the viral hepatitis program. So some of the key challenges, awareness is still an issue. The program issue of funding is an issue. Access to services due to high cost, but we are working on that with China and other to reduce costs. Out of pocket, we are trying as much as possible to source for mobilized funds from different programs so that we can allow more people to get access to drugs. Capacity building is one of the key areas we've been there also. It's still ongoing. By next year again, we are still going to continue to train more healthcare workers to be able to provide treatment. And finally, is the fact that we'll be able to develop MIA tools for viral hepatitis, and we're going to integrate that into HIV program so that maybe, as I've said, next time we'll have a better report for Nigeria. Thank you very much.
Thank you very much, Ghana. We'll now turn it over to Dr. Aman Wakid from Egypt to talk about building national information systems to track progress toward hepatitis elimination goals. Aman?
Okay, so thank you for inviting me to share our experience in Egypt. And over the next few minutes, I'll show you how we handle the hepatitis C problem in Egypt. This first slide is from the NHEP, or Egypt's NHEP. And the prevalence of hepatitis B in Egypt is 1% or slightly less. And the prevalence of hepatitis C currently is less than 0.5%. However, how did the problem in Egypt start? Until 2016, Egypt had the highest prevalence of hepatitis C in the world. And in 2016, 7% of the adult population were viremic. And this number was 5.5 million persons infected with hepatitis C. In 2006, the National Committee for the Control of Viral Hepatitis was established, and it established dedicated hepatitis centers connected by a virtual network to a central database and central server. In 2014, we introduced direct-acting antivirals. And initially we had one center, which in 2014 were 26 centers. And with the introduction of direct antivirals, patients would register online using their computers or cell phones to have treatment, and they will get an SMS with the appointment in one of these centers where they would go and be evaluated and receive treatment. By 2018, we had treated more than 2 million people, but the number coming for treatment decreased. And because we had treated everybody who knew of the diagnosis, patients would come for treatment. By 2018, the numbers decreased, and we estimated that there were still 2 to 3 million patients who were undiagnosed and needed to be found and treated. And we decided to have a national hepatitis C screening program. Let's screen everybody once and for all and find everybody with hepatitis C and treat them all. We decided to screen everybody over the age of 18, which was a population of 62 million, and all teenagers between the age of 12 and 18 who were in middle and high school. The treatment centers had increased to more than 300 treatment centers. And we used every primary healthcare unit in the country, which are more than 15,000 primary healthcare units, to screen persons who go voluntarily to be screened. Patients or persons would come with their national ID to be registered in these centers, and their data would be transmitted to the central database. They would have a rapid test for hepatitis C and blood glucose and blood pressure and weight and so on. and the data would be immediately registered in the central database. And if they are positive, they will immediately get an appointment through the system to one of these evaluation and treatment centers, the closest one to their screening area, to be evaluated and treated for hepatitis C. The system had, we could monitor immediately, minute by minute, the number of persons coming for screening, the numbers positive, the total numbers in each neighborhood and in each one of these evaluation and the 15,000 evaluation and treatment centers. And we could immediately minute. The results, this was a massive screen.
Thank you. Thank you, John. Thank you again for inviting me. My presentation is focused on hepatitis C. And let me start with a mention to Spanish National Strategic Plan, pioneer in Europe. And our plan has allowed Spain to be recognized as one of the countries that has advanced the most toward the objectives of the WHO. The plan was approved in 2015, and as a consequence, the Ministry of Health in our country provides quarterly the number of patients started treatment with DAAs, universal treatment, of course. And as you can see, these are the numbers. Until September this year, we treat almost 165,000 patients in these 8 years of plan. And as you also can see, the mean of treated patients quarterly basis was very high, more than 10,000 per quarter in the first years after approval of plan. And it was followed by a decrease, especially marked after COVID-19 pandemics, as discussed this morning. And currently, we are treated less than 2,000 patients per quarter in our country. Of course, our feeling, I think everybody agreed that we have to combine two routes to get HCV elimination. First, macro elimination by screening in general or aged population, and micro elimination with specific actions in vulnerable population and priority settings. An example of first is the specific plans in Spanish regions, also called autonomous communities. So several regions in Spain has developed specific plans against Hep C, but at least two of them, Galicia in the northwest of the country and Andalusia in the south, have implemented plans with specific campaigns of screening, opportunistic screening based on age since 45 to 69 years old. And for instance, in Galicia, this plan started less than 1 year ago. Until the end of September, they test 63,000 people, opportunistic screening approach with a prevalence of viremic infection of 0.13. So this is lower than the previously communicated number by Minister of Health in Spain, 0.22. Other approach launched by Spanish Alliance, Alianza para la Eliminación de las Hepatitis. Other approach is HCT-free. HCT-free is a movement inspired by fast track cities in HIV setting to get the involvement of cities in the fight against Hep C. HCT-free movements works with two fundamental objectives. First of all, awareness and communications, general population for detection and diagnostic case, and of course, and more specific actions in vulnerable groups with the coordination with NGOs and local entities, close working with the local entities and the local governments. We present recently, 3 weeks ago in Boston in the AASLD meeting, the preliminary results of the cities involved in Spain in the program. A significant proportion of Spanish citizens are participating in the local programs of Hep C in the program of the Alliance for the local contribution to eliminate Hep C in this setting. And let me conclude this very short presentation that first, Spain may be the first country among developed to meet the WHO objectives to eliminate Hep C before 2013. Before we mentioned the estimation of Polaris Observatory, and according to this data, Spain could eliminate Hep C around 2025, 2026. Of course, it is essential to develop simplification and decentralization strategies and involve all stakeholders and administration, even local administration, and the HCT-free movement incorporates all the local entities into elimination policy. And I think this is very important. The current rate of active HIV infection in my country may be around 0.15%, and I think this is very close to the WHO HCV elimination indicators. Thank you.
Thank you very much for that excellent presentation. We're going to turn now to China, to my colleague Li Mingyang. He's with China Liver Health, and he will be assisted by a translator, Patrick. We will be talking about prevention and treatment policies for hepatitis B in China and the positive effects of social organizations in hepatitis C elimination.
尊敬的各位专家，大家上午好。这个麦克风，对，好。尊敬的各位专家，大家下午好。首先特别感谢受全球消除肝炎联盟来参加今天这个会议。
So dear distinguished guests, it's my honor to be here with everyone from different countries, and we're happy to give this short presentation.
我今天给大家汇报的主要是2方面的工作吧。
So there's 2 aspects I want to talk about today.
第一个呢是中国的这个乙肝防治现状。我们国家约有14亿人口，新生儿呢 在24小时出生之内，原来从92年的22%提高到了2022年的95%，就是乙肝016的这个接种率。从这个 CDC 显示呢，我们国家约有8600万的这个乙肝感染者，现在这个乙肝的诊断率呢是约有24%，治疗率呢约有17%。
Okay, that was long. So the first topic is China's hepatitis B prevention control policy. And as you can see from the first paragraph, China has population 1.4 billion as used to be the most populous country, but not anymore. The rate of the timely vaccination of newborns with Hep B vaccine with 24 hours of birth has increased from 22% in 1995 to 95% in 2022. And the rate of full Hep B vaccination coverage has risen from 30% in 1992 to 99% in 2022. The results of China's CDC survey in 2014 show that the Hep B surface antigen positivity rate of the 1 to 29 years old was 2.94% and 0.32% in children under 5 years old. According to the Polaris International Epidemiology Collaboration in 2016, the prevalence of hepatitis B surface antigen in the general population of China was 6.1%, and there were still 86 million cases of chronic HBV intervention given the population. The law for prevention and control of infectious disease, regulations of the administration of medical institutions, and the measures for the management of hospital infectious have been promulgated to regulate the diagnosis and treatment activities of medical institutions, which have not only reduced the incidence of Hep B, but also reduced the incidence of other blood-borne diseases.
OK，接下来这几个片子呢，是我们中国政府在这几年过程当中出的一些相应的文件，就不用全都念。
These slides are mostly some preventions and treatments for Hep B published by the Chinese government, so you can read through. We're not going down here. Yeah.
好，今天跟大家主要报告的是这个我们在中国北京人民大会堂启动的中国消除丙肝联盟这个公益项目。
So Mr. Li is from China Liver Health, and it's an NGO organization. This whole project was initiated in 2017 on September 3rd, and project held a press conference at the Great Hall of People in Beijing, where these people attended as the founders.
项目呢是以政府指导，以我们NGO 社会组织中联肝健康促进中心主办，以一些学会共同协办。
It's guided by the Chinese party, the government, but it still is an NGO, and program is run and operated by officials from, the experts and scholars. So it's not completely government controlled. Yeah.
主要围绕4个这个方面开展工作。第一个是筛查检测，在筛查检测方面呢，我们一共是做了一呢是世界肝炎日，筛查了是5万人，筛查抗体阳性人员呢是达到了4000人，比例是8.25%。第二个呢是在丙型肝炎高发区做筛查，筛查了是56000人，抗体阳性呢比例达到了5.54%。第3呢是支持医院的常规筛查，第4呢就是这个全人群的筛查，比例呢是0.46%。
Okay, so there are a lot of numbers, and what the China Liver Health has done in the past few years from 2019 to 2021. So the organization has tested nearly 120,000 people for Hep C screening nationwide, and 7,400 people were diagnosed positive, or 6.06% of the population were found to be antibody positive. And some social campaigns on World Hepatitis Day or National Hepatitis Awareness Day, volunteer screening, public service day screening, around 50,000 people were tested. And out of this population, around 4,000 antibody positive people were found. The ratio was 8.25%. Also, Hep C public health screening for residents in K population or high risk areas, the prevalence rate were about 5.54% of the whole population. And also there are some support for routine in-hospital screening. And the positive rate was 1.24 for the hospital test screening. And for some general community screening, the positive rate was 0.46%.
基于以上的这个筛查工作呢，了解了中国的这个丙型肝炎的流行病情况。
The Hep C prevention and policies in China.
我们在这个农工党中央的这个指导下，发起多家单位共同编写了《健康中国2030消除丙肝威胁行动白皮书》，来去动员全社会关注丙型肝炎，然后通过两会提案交到了国家。
So there's a white paper book. It was launched by the China National Farmers and Workers Party Central Committee in 2020 led by Liver Health Promotion Center of the China Federation of Liver Health and other units, and they jointly prepared and promote the white paper Health China 2030, eliminating the threats of Hep C, and submitted a proposal for the elimination of Hep C. There are the two meetings usually held in March, if you know, is to mobilize the whole society to pay attention to Hep C elimination.
第三方面呢，我们是在各地中国的政府去推动丙型肝炎的医保落地。原来中国的丙型肝炎最高的时候应该是卖1万美金，然后我们推动政府医保落地，最后应该是不到1500美金。
So the party or the government is also working with the local government and communities to help with the copay for Hep C prevention and treatment. And the used price for Hep C was around $10,000, but now it has been decreased to $1,500. So it's a significant help.
药品可及性有了之后呢，我们又组织专家编写了中国丙型病毒性肝炎院内这个筛查管理流程。这个筛查管理流程相当于是中国行业专家的标准。
So with the access to medicine, the party or the organization also launched the white paper book to help eliminate and to standardize the treatment regarding Hep in terms of Hep C treatment.
最后推动了就是推动了中国卫健委等9个部委发布了这个中国消除丙肝的国家计划。
So this plan was launched by the National Health Commission of PRC on the issuance of the World Program Action to eliminate public health hazards of Hep C, which is the overall objectives is to completely or achieve the goal set by WHO about how to, we can really eliminate Hep C in China by 2030.
好，我就
Yeah,
就给大家汇报这些，谢谢。
That's pretty much that's it. And it's a short introduction to the China liver health with the Mr. Liver.
谢谢。
Thank you.
Thank you very much. Tremendously helpful. We're going to take a short break here for 10 minutes to arrange the next set of slide presentations. So it's about 3 minutes after the hour. We'll return at 15 after the hour. We'll rejoin. So everybody online, please take a break and join us back at a quarter after the hour, wherever you may be. Thank you. Okay, everyone, welcome back. We're going to now be turning our attention to the importance of decentralization of care to expand access to testing, care, and treatment services for people living with HBV or HCV infection. And we're going to hear some examples from Brazil, Portugal, and Bangladesh. So let's start with Brazil. We'll hear from Dr. Angelica Miranda, who's from the Ministry of Health of Brazil, to explore how to incorporate nurses into the screening programs for hepatitis. Angelica.
You can see. Yes. Thank you for inviting me to be here, and I'd like to thank Lindsay for preparing the first slide with the Brazilian data. And we see that we don't have an elimination goal for hepatitis B in general, but we have a national plan. And we have been working with NHEP elimination of hepatitis B and the elimination of hepatitis C in Brazil. We hope we can get it, because now we have 0.52% of the prevalence of hepatitis B and 0.53% the prevalence of hepatitis C. We work in Brazil with the detection rate, then we don't have the incidence rate. We have the new cases that we detected. And for the mortality rate, it's not here, but we have 0.2 per 100,000 inhabitants for hepatitis B and 0.5 for hepatitis C. And that's here that I saw that it was said that we don't have the proportion of persons diagnosed or the proportion of persons in treatment for both infections, but we have been working in a mathematical model, and I think that 224 we will have this data. And before talking about decentralization, I decided to include 2 slides to give you a general idea of Brazil. We work with a universal public health system, then everything that the Ministry of Health recommends, the Ministry of Health needs to pay. Then that's the problem, because looks easy, looks well, but it's very complicated because we have a very big account, not compared to China, because then we have 200 million inhabitants and China more than 1 billion. We look at a small country. But then we have 5 different geographical regions, and they look like different countries. The necessities, they are very different, a lot of diversity, a lot of inequalities as well. And we have a department in the Ministry of Health that is responsible to organize all the policies for HIV, hepatitis, STIs, and tuberculosis. And then why we need to decentralization care? Because in the beginning, the hepatitis was taken by infectious disease physician, gastroenterologist, and hepatologists. And now we saw that it was not working. You needed to take advantage of the primary health care facilities, that we have around 75% of the population covered by the primary health care. And we initially took care about the family health physicians. They started to help in taking care of hepatitis, but we saw that it was not enough. Because here we had the last decade cases of hepatitis B and C and A, but here we are talking about the C, that we have the goal, the elimination goal. And you can see that we have 2 points. In 2014, that we changed the notification criteria for RNA to DNA. And then we have the COVID. The COVID, because in 2020, we almost stopped all the screening programs in Brazil, but not in antenatal care. It was the only one that we kept going. But then we can see that we are restarting again. And for working with the elimination plan, we need to organize ourselves. And we thought, despite working with general physicians, we also need to include nurses and pharmacists and all the health professionals that we work in the primary health care units. And I just decided to show this slide because we have been working blocks. We have the HIV, syphilis, and hepatitis B. And we can see in pregnant women, in the blue are the hepatitis B. We have a low rates of prevalence in hepatitis B in pregnant women. And in children, we have a disorganized line. It's because of the notification system that we are working to improve it. And we started in 2017 with the subnational elimination of HIV. And then in 2021, we included syphilis. And now in 2023, we include the Chagas and the hepatitis B. Then we are going to work and we need to improve our system. It has been very interesting because better than being eliminated, we can improve the system in the communities. We are including nurses and pharmacists and general physicians to work how they can do better for the elimination. And then when we decided to include the hepatitis, we decided to see other countries' experience. Then we did a search with what other countries were doing to eliminate the hepatitis B and C. And we saw the Australia experience that they had been working with nurses and general physicians as well. Then we tried to organize our system like the Australia was doing. And then we started to see that we already had some national legislation that could help us. We have a law from 86 that did the regulation of nurses' activities in the country. And they were supposed to work with screening, diagnosis, and treatment in national protocols. Every disease or every infection that had a national protocol that should be followed, they were able since 86. And we have the Federal Council of Nurses. Since 1997, they recommended that nurses could do that. And the National Primary Health Care Policy, then we took these 3 laws and prepared a document to prepare nurses to be included in the hepatitis model. Then in 2020, the Minister of Health prepared guidelines explaining how the nurses should be included and what they should do for hepatitis B and C, and also hepatitis A and D. And then it was not enough only do that, and then we started to provide a course, an online course in the beginning because of the pandemic, and then some parts of them on site to prepare them to screening, doing diagnosis, and follow the treatment protocol for hepatitis. And up to now, we have around 10,000 trained nurses. And what I can say until now, we are doing well. We could improve the screening for hepatitis C in the primary health care units. We still have some challenge because the Federal Council of Medicine were not very happy because we were allowed nurses doing diagnosis and the treatment because they say that it's a physician act. But we are trying to explain then that it's not overlap the physicians, but it's working together, and the nurses do the screening start the diagnosis, and then they follow the patients for the specialist. And for now, we're doing well, and we hope in the future we can tell you that we could approach even more to the elimination of hepatitis B and C because of the decentralization from the specialists to the generalist physician and nurses. I stop here. Thank you.
Very much, Angelica. Let's turn now to our colleague Rui Marinho, who's from the Ministry of Health in Portugal, to explore expanding screening to pharmacies, prisons, and drug treatment programs for HCV elimination. Rui?
First of all, thank you very much for the kind invitation. I'm a gastroenterologist, hepatologist, and clinical addictologist, and now the medical director of the Hospital Santa Maria, the biggest one in Portugal, and also coordinate the national program for viral hepatitis. I will choose only three aspects: pharmacies, prisons, and drug treatment programs, but only a small 5 minutes summary. Portugal has created some national priority programs, and since the last 3 years, there is autonomous program for viral hepatitis. I am the first coordinator for this program. Portugal has a long history. It's not the best in the world, like Spain, for example, but we have a long history of dealing with hepatitis and liver disease, like one of the best liver transplants system in the world, a national health system free for all since the last 40 years, one of the most efficient in the world. So throughout these years, we have given treatment free for all patients. Even the poor patient don't pay anything. If even the alcoholic or the homeless can have the best treatment for hepatitis B or C. Regarding the activity of pharmacies, we are a small country, 10 million inhabitants, 1/4 of Spain, and we have a very good system of pharmacies. It's a national system, private national system, with more than 2,000 pharmacies, and the pharmacy have been collaborating with us, with Portugal, in terms of needle sharing. It's private funded by the National Association of Pharmacy. Throughout these years, it's 30 years, 3 decades of needle sharing, which is very good, a very innovative way of dealing with drug addiction. After the revolution in Portugal, 1974, there is a uprising of drug addiction, people coming from the past colonies, Angola, Mozambique. So perhaps 1% of population taking IV drugs in the past. So the pharmacies, more than 2,000, went to the field and provided free needle sharings with 3 generations of kits. And in these 3 decades, 60 million syringes changed. The HIV in drug addiction was a big epidemic in the past, but now, as you can see in this yellow curve, has reduced a lot, and also with this activity of needle sharing. We are trying to include the pharmacies for providing tests, rapid tests, but it's still ongoing. Regarding prisons, we have around 50 prisons. We are trying to approach, we have a law, a national law for testing all the prisoners when they enter the prison, hepatitis B, hepatitis C, HIV. And we are trying to approach hospitals, big hospitals like mine, and big prisons and small prisons, avoiding the prisoners to come to hospital with all the guards, all the things. So we have a law for all prisoners, almost 50 prisons. We have tested all when they enter the prison, and the percentage of hepatitis C was around 7%. In the past, 12% is reducing, and hepatitis B is around 1%. We have been treating free all the prisoners that are getting tested, and the doctors and the nurses goes to the prison. Also doing fiber scan, ultrasound. Regarding drug addiction, we have a lot of NGOs in the field contributing, in my point of view, a lot for the social pacification, because there, as you know, there is a lot of crime related with drug addiction, and they contribute to the approach of mental diseases and also the crime. I choose one of the best NGOs called Ars do Pinhal. They have a long history of testing in the streets where the people live, and after the COVID, there is an increase in the people living in the streets. And one innovation we have approved in Portugal, the consumption room. We have two, one in Lisbon, other in Porto. And in that consumption rooms, we have money right now to do the screening for hepatitis C, for hepatitis B. I went there several times, and it's very interesting to see people injecting themselves and avoiding deaths in the street, overdose deaths in the streets. Portugal has a very, very, very low rate of overdose deaths. So that's all. This is our nice logo.
Thank you for that. There was a lot there in a very short time. I greatly appreciate that. Now let's turn to our colleague, Dr. Muhammad Ali from the National Liver Foundation of Bangladesh, to talk about training the public health workforce on hepatitis screening and treatment.
Thank you. Like this. Good afternoon and welcome everybody. I'm really thankful to CGHE for giving me this opportunity for this presentation. The difficult task given by Lindsay, the training the public health workforce on hepatitis screening and treatment. So let us see what we can do. Come for our, what is there or not? Here, darker. Yeah. It's okay. Yeah, just use that. Yeah. Okay. Again, I'd like to thank the CGHE for making this National Hepatitis Elimination Profile, and which is really working as a driving force towards elimination of hepatitis B and C in Bangladesh, and particularly working as an important tool for making advocacy to the government. And here you see prevalence of hepatitis B is 6% and C 0.6%. And another problem is the Rohingya migrants. It is an additional burden for us. It is not for other countries. That about more than 1 million Rohingya refugees are staying in our land. since August 2017. And we don't know when they will leave the country, or they are told when they will leave the country. So we made a study, and I'm happy to announce you that we made the study and discussed this with John in London meeting. And John told me, then why you are not making a, so you got this such an important study, why are you not publishing? Then I told John, so could you arrange some publication in a well circulated journal? I'm very thankful to John for making this publication, and Coalition is one of the co-author of this publication, and it showed that 7% having hepatitis B, and about more than 22% is in hepatitis C, and there is no other treatment profile, and no preventive measures and other things. Just these people are there, and what they are doing every time they are trying to enter to our host country. This is a potential problem which is separate from other nations, and it causes the death about B and C about 8,000 annually. And we are working. Our government is also working, but actually these publications, other things are not so significant. That's why you will not get the data less. But there are also some positive things. I'm thankful to NHEP for you putting this forward. One thing is this: in 2019, our vaccination program, particularly children, achieved the WHO goal, that is less than 1% for 5-year children. It is one of the 3 countries in the Southeast Asia region to achieve this goal, and it is we achieved this in 2019. Another thing, you see, the first this antiviral DS sofosbuvir was that the generic version was made in Bangladesh, and this was started importing to the various countries, and the first country in the world to marketing this sofosbuvir in the world. Another advantage of this is COVID has given to us this PCR laboratories, which randomly we are using. After COVID, all these PCR laboratory facilities has been incorporated with the government, and now government facilities for PCR testing has been much more reinforced after COVID. So these are positive things in respect of Hep B and C in my nation. What is this? It is not changing. No.
It's not advancing.
This task, that is the health workforce, as in 2006 WHO described. There's the heart, the workforce is described as the heart of the health system in any country. Development of that is health workforce is the heart for the development of the health system in any country. That is, WHO told that education and training of the health workforce is essential for universal health coverage, USC, when you are working. That means this that is the training of this health workforce is the vital. And our CDC is working, particularly conducting integrated training program and for public health purpose. And there are operation plan of 7 components. And among this, one is the AMR, another one is viral hepatitis, another is waterborne disease, disease control. And this is for the development of the workforce incorporated with these diseases. Most important thing and most recent development is a separate component only for viral hepatitis control is proposed in the 5th health population nutrition program, the government of Bangladesh. And it will start working from July 1, 2014, and it will continue for 5 years. This is only earmarked fund and everything facility only for viral hepatitis, not with the combination of other disease. This was my point, since I think I can tell you for 5 years, I was telling that this. Until and unless something separate for viral hepatitis distribution, separate fund allocation, separate facility creation, viral hepatitis will not be controlled. It will not be possible to control. If you give us some money, 60 million or 70 million or something like this, incorporated with so many diseases, 2-3 diseases, then how much viral hepatitis will got, I don't know. So a separate component has already made, and government is going to finalize and make it functioning since July 1, 2024, and it will continue for 5 years. I think we'll get a very good response after this, when it will be functioning. This is one of the achievements which we are doing since a very long time. Over 10,000 healthcare staffs have already been trained up. In the NHEP reported 5,000. By this time, we have crossed 5,000 more. Government is continuing training healthcare professionals, BFCs, and treatment at district, subdivisional level, and decentralization of the services. Government is also committed for elimination, as well as the fulfillment of this SDG, the goal for viral hepatitis control by 2030. This is the most important slide which I like to introduce. First, my country. You see, a small country of 148,000 square kilometer. One of the, and you see, it is bearing more than 165 million peoples, and one of the 10th populous countries of the world. And you see, another important, you see, there's a rural population is more than 68%, and urban is 30%. These three components: over small country, overpopulated, and 38% peoples. So 68% people in the rural. So all these have got the important factor in controlling viral hepatitis. That's why I put this slide. Another thing is this most important development is government has made the national operational plan for elimination of viral hepatitis in Bangladesh. And they have given first target for 5 years, 2023 to 2028. The first target will be, let us see the first 5 years what happened. Yes, if you can, if there is any shortcomings or other things, we'll make another 2 years program to fulfill it by 2030. This is the main aim, and I was present in all the meetings. And another thing regarding this today's topic is the Bangladesh Health Workforce Strategy also has been made. Also, 2023, they have made for development of the health workforce. So, the two important strategies working together. One is the National Operational Plan. Another one is the Health Workforce Development Strategy in Bangladesh. And this is that program, and these were the 3 meetings was there, combined meeting, WHO Southeast Asia Regional participation, and I was there representing National Liver Foundation of Bangladesh, gave the feedback of my experience in the field of Bangladesh, because I have traveled almost all the districts of Bangladesh and making program awareness and other and childhood vaccinations. More than 7,000 orphan children of different children, orphanages, government orphanages have been vaccinated by National Liver Foundation throughout the Bangladesh. And I visited all the districts of Bangladesh, and I gave my experience. And there were one meeting was the National Operation Plan finalization. Another meeting was the cost of the analyzation. Another meeting was on mapping the key populations for control of viral hepatitis. So in all these meetings, we participated cordially and gave our feedbacks, and everything is prepared according to our great satisfaction. And this is the for a diagnosis, we have got this step, this union, sub-district, district, and division, 8 divisions. And union level, the rapid test, even sub-district also still we are keeping the rapid test. But when it will come to the district hospital, there will be RT-PCR, and the divisional headquarters will have the all the facilities, starting from the medical colleges and other specialized facilities, liver hepatitis, complicated hepatitis, cirrhosis, liver cancer, and all these management strategies, diagnostic facilities. Then the treatment facility also like this. There's in the union and sub-district level will be diagnosis, and they will refer. And then district level will be interventions, and not everywhere this hepatologist or gastroenterologist will be needed for treatment of hepatitis B. The trained GPs can treat those patients. That is, we kept in this strategy. And finally, in the divisional headquarters will be final treatment by the hepatologist. And this is the profile for the diagnosis, and this is the profile of the treatment profile, which has been chalked out by the government and accepted and submitting it. National Liver Foundation are also working for a long time, and hepatitis B and C information and testing among medical students. Medical Student Society of Bangladesh is there. They are incorporated with the National Liver Foundation for a long time. And whatever, suppose a poster we publish, immediately they decentralize this, disseminate it throughout the 109 medical colleges. So they are intimately working with the National Liver Foundation of Bangladesh. And I called them, and in very many workshops, and told them about the mode of transmission, prevention, vaccination, treatment, self-protection, and also taught them about the that is rapid testing of hepatitis B themselves, so that they can do this for their family members, friends, and others, and others. So they decentralize this rapid testing. Another group is the we call for that is midwives. Particularly, we call midwives for prevention of mother-to-child transmission. So we and the Midwife Society is also incorporated with the Liver Foundation. And at that time, you see the CDC director was there. He is sitting with these midwives, director himself, and UNFP representative. I think she is from Amsterdam, and she is also there. And we have got a very comprehensive workshop to teach them. Suppose finally, I told them, then you are attending the pregnant women. You ask whether your doctor has told for testing of hepatitis B. If it is okay, show me the result. If no, you try to make a test for this pregnant lady and learn how to do a rapid test. At least this test should be done for the pregnant women so that she should not suffer. And I told them, and then one rapid test in pregnancy can save 2 lives, mother and child. So they are very much positive, and they are already working throughout the nation. In summary, distinguished audience, I like to say that National Hepatitis Elimination Profile, NHEP of CGA, is a useful means and guidance for planning elimination policy and viral hepatitis in a nation. I will tell broadly. And training testing is what happened in Bangladesh, mainly is centered in the urban areas. So government is trying, and we are also advocating for making in the rural areas, because more than 68% people are in the rural Bangladesh. And training of nurses for dealing diagnosis and non-specialists for treatment of hepatitis C will bring mass population under care. I am very much pleased with the presentation of Brazil Angelica. Then really, they are nurse already authenticated, already permitted that they can make advice diagnosis test, and is a very good decentralization. And I think it will work very good, and I will try to implement that model in Bangladesh. You know, this about I told about the Rohingya refugees, and they are the potential. So what do they? I like to make advocacy to those working in the Rohingya camps in Cox's Bazar. They should learn testing, and they should make testing of these Rohingyas of hepatitis B and C, so that they can be diagnosed. If nobody going there, you do this testing for these Rohingyas. Make a rapid test and see positive or not. Tell the doctor, or if the doctor does not attend, you can inform this foundation. We'll try to do these things. Recent study has been looked at, particularly the COVID-19 effect on the viral hepatitis, as a joint study with the Hiroshima University, Coalition for Global Hepatitis Elimination, and National Liver Foundation, in which John and Lindsay is also one of the co-authors. And it shows the drastic reduction of these hepatitis B and C services during this period of COVID-19, about 80–99%. So what is different? This should be reinforced, and all those services should be back to this. So I think in the combined coordinated efforts of the government, civil society organization, and private healthcare facilities to train the professionals, health professionals, can control this viral hepatitis and give the elimination 2030 fulfillment of the elimination goal in Bangladesh. Thank you, everybody, for patience sharing.
Thank you. Thank you again. Now hear from Mr. Charles Ajay, who's with the Hepatitis Alliance of Ghana. He'll be talking about amplifying hepatitis C testing, promoting patient access to treatment through the involvement of civil society. Insights from the Stop Hep C Ghana project, which was featured in the New York Times yesterday. And we will share that link to that article in the chat in this webinar, and share it with everyone in the room as well. So Charles, welcome.
Thank you, John. So on behalf of the people of Ghana and the Hepatitis Alliance of Ghana, I want to extend our sincere appreciation to the coalition. We have benefited a lot from the coalition, and that is being translated into the kind of activities we are currently having in our country. Thank you very much, John. So I'm talking about amplifying hepatitis C testing and promoting patient access to treatment through the involvement of civil society organizations. So let's talk about the burden of hepatitis C in Ghana. So we have almost about 4.58% of the adult population having viral hepatitis C. But then there is that geographical variation whereby you have more of the patients with hepatitis C in the northern part of the country. And we have a prevalence estimate ranging from about 8.3% to about 14.4% in the 3 northern regions of the country. But the exciting news is that we received support from Egypt's government, and that was very exciting because as a civil society organization, we appreciate the enormity of the struggles the patient goes through. So when we got the news that Egypt is ready to support us, and I mean the hepatitis community, with about 50,000 treatment opportunities for these patients, it was very exciting. So we began this treatment in March. And you could see some stakeholders were gathered during the lunch, and John happens to be part of the team. So when we got the news, again, we sat down to also think about what we could do as civil society organizations so that we can all benefit from this project. So we developed different models, and that is what I'm touching on this afternoon. So the first model was the multi-stakeholders collaboration model. So we appreciate the fact that we have different stakeholders, and these stakeholders are very critical, particularly when it comes to the whole treatment cascade. So we started engaging gastroenterologists, we started engaging the National Viral Hepatitis Control Program, the Ministry of Health, the Ghana Health Service. But more importantly, this program was implemented by the Ghana Health Service, also by the Ministry of Health, and through the support of the World Health Organization in country, and then the coalition as well. Then knowing that healthcare providers are the main individuals who serve as the source of information for viral hepatitis in the country, we started also building their capacity, because unlike hepatitis B, that is well known by even the lay population, hepatitis C seems to have a unique, information, and individuals were not privy to that. So we started building their capacity. The reason being that these people are the source of information. In fact, almost about 84% of the population say they receive hepatitis-related information from healthcare providers. So obviously, there was no way we could take this population out. So this is a session of individuals who were trained. We had a hybrid training, and we trained almost about 2,000 plus healthcare providers across the country to make sure that they could recruit patients, and they could also link patients to care as soon as they are identified. Then the third model is what we call the supportive care model. So here we created a call center. So we set up a call center in our organization. And what we did was the Ministry of Health through the Ghana Health Service launched a registration form, which was a Google form. So these forms, when they are filled by the patients, then they were sent from the ministry to our organization to screen and begin to call the patients, and then also connect them to the laboratories where they could have some important labs done before they go for the treatment, because treatment candidature was also dependent on your lab results. So that is what we did, and we screened quite a number of the patients whose details were sent to us, and we called them and linked them to care, depending on the region where they find themselves. So from there, we move also to the community and began to also do some testing, because unlike hepatitis B, that we have quite a number of the population tested, hepatitis C wasn't like that. So we needed to go to the community and then begin to talk about it and begin to also screen individuals, and those who were positive were also referred to benefit from the treatment. But one major challenge or barrier happens to be the tests, and I mean the laboratory investigation. So individuals were only considered to be eligible if they have a viral load, and that was very costly because we don't have viral loads at the primary care level, and even at the secondary care level is quite a challenge, but at the tertiary level. But then we have private laboratories that offer these services, and as an organization, what we did was to have a conversation with them and say that, can you bring down your prices? So they reduce the cost of viral load by almost about 50%. Some reduce it by almost about 70%. And we also negotiated with these laboratories to set up sample collection points, particularly in the 3 northern regions where they have a lot of the patients, but none of the labs were operating there. So we negotiated with them, and they set up a sample collection point in all these 3 regions, and then began to take samples and run for viral load so that these patients can also benefit from the treatment. Then again, we also were linking the patient to care. So depending on your region, we're having almost about 16 treatment centers across the country. We are only 32 million, and we have 16 administrative regions. So what we did was we set up treatment centers in all the 60 regions, and that was done by the Ministry of Health and the Ghana Health Service. So what we had to do is when the patient call, and then we give the patient the specific labs to do, and the patient is done with the lab and is sent to us, and we check and see that the patient is eligible for treatment, then we refer the patient to the region that is very close to the patient. And we're having case management teams in all the regions. So once you go there, you are given a priority, or let's say a treatment that, you are given attention that you don't have to spend a lot of time in the hospital because you are being referred by our organization. So that is exactly that happened. And as a civil society organization, I cannot talk about the impacts of the project, and I mean the patient stories. And that is the last slide. The project is still ongoing. We started in March. Evaluation and all that is ongoing, and that is at the national level. So I cannot share information on the real data in terms of the impact, but what I can share is what the patient told us. And they said, one patient said, I have completed my treatment today, and for the first time, I had a good sleep, knowing that I can pursue my future dreams. And then another patient said, initially, I thought this was one of those projects that the media hypes it, and you see no action. I took my treatment from UGMC, that is one of the hospitals, and the doctor was awesome. My fears are gone, and now I know I can hold the future. Thanks to you guys. And then another patient says, sir, I am taking the treatment. Strangely, all the funny feelings I used to have are gone. I feel that the medicine is working. I can't wait to share my story with the rest of the world when I'm declared cured. So these are very powerful statements we receive from the patient every day. And for us, we are excited about it as an organization, particularly given our role that we have played in this Top Hep C Ghana project. Thank you very much.
Fantastic work. Now let's turn to Dr. Loretta Condili from the Istituto Superiore di Sanità in Italy. We talk about implementing general population HCV screening. Welcome.
Thank you. Can I move forward? Okay, thank you. I would like to thank the coalition for the invitation and for giving me the opportunity to present with you today the update on HCV elimination progress in Italy, focusing specifically in implementing general population HCV screening. So just few data on the epidemiology of hepatitis C in Italy. As you have seen here, Italy was one of the countries with the major burden of deaths from hepatitis C in Europe. So it's 38 per million inhabitants, when other countries has less than 3 times less mortality rates. This is due to a cohort effect of hepatitis C through nosocomial transmission in Italy, which bring all this kind of mortality for people when drugs for DA drugs arrived in Italy. So we had a huge burden of people with cirrhosis and hepatocellular carcinoma. So treating them decreased the rate. And after that, a new epidemic wave after the year 1990 was observed in Italy due to drug use. So these are 2 kinds of cohorts in Italy that have to be addressed in order to achieve the elimination. And regarding the policy, I think that the policy in Italy has been really very good in progressing hepatitis C elimination goals. And we see here in the first years in 2015, 2016, we had only the prioritized access to antiviral treatment due to a huge burden of people that needed to be treated, and at the same time of the high prices of the drugs. But after that, on 2070, the universal access was resulted cost effective. So lots of work to convince policymakers that the universal access for the DA drugs was cost effective. And so we had a dedicated fund for innovative drugs as it was DAA. And we had the access for all the diagnosed people to DAA drugs. And in 2019, we have also a document that active screening is also cost effective. So it was implemented in 2020 also together with the universal access to antiviral treatment, also proved specific fund for screening of HCV in order to bring out all the infected people that was undiagnosed or diagnosed and unlinked to care. So today we have around 257,000 people treated since 2015. And as you see here on the right part of the graph, you can see that we have these two kind of cohorts. So the older cohorts and the younger cohorts that are together affected with the hepatitis C. So the strategy should be all adult people over 18 years of age should be screened for hepatitis C. And another work that we have done to persuade policymaker on approving the screening is showing how was the decrease in chronic liver cancer and in the hospitalization, which is a significant decrease after the year 2015. And so, as I said, 71.5 million euros was allocated for the first and second level of screening up to the years 2023, and it was up to the years 2022 as an experimental screening in order to validate also the prevalences, because the prevalences were all estimated, and it focused PWID inmates and general population cohort birth as a birth cohort 69-89. And this is a little bit different from what usually is addressed, because we know that the older population has higher prevalences, but the older population has also been cured by interferon DA treatments, and also the youngest population should be addressed also because the incidence rates in the younger population is higher because they have higher probability to transmit infection higher than the older population. So on the right-hand side, you can see what is the estimated number of the people that need to be diagnosed and cured. So it's more than 300,000 that need to be addressed yet. So for the total prevalence of 0.7 to 1%. And regarding the screening approved, as I said, by law, it is focused on the country health department because, as you know, we have lots of regions in Italy. There are more than 20 regions that have their proper administrative rule to persuade the screening. However, the central government gave indication on the involvement of general practitioners and also opportunistic screening in addition to the health department of each region to address screening with this kind of fund given by the central government. And these are the results. And I can say that this is maybe the first time that I'm presenting these results here in this setting of the coalition. And we have almost 1 million people, 860 people from general population, so no at-risk people. And as you see, there are some of the regions that you can see in underlined with in green that have activated the screening for general population, and the other regions that do not have implemented yet screening. And the antibody prevalence is exactly what is estimated. But something that I leave also for you to discuss is the lower rate, much lower than what is estimated of the active infection. So as you see, it is expected that these people are unknown of their infective status. So as we know from the natural history, we should expect not 25.5, but 60, 50, 70%. Instead, we have around 26% of active infection. So this could be explained in two, or there are people that know that they are infected, and so they go to get tested only to see if they have infection, active infection, despite maybe they are cured. So this is one of the reasons. So low awareness for people. So we have not catch yet the real asymptomatic and unaware people. And the other reason is that maybe we need to reevaluate the estimation, because maybe the active infection could be less than what is expected, as the data from Spain also have shown in the general population. So maybe some concerns on what we know regarding natural history of hepatitis C right now. and a few data on the key population screening, which is addressed also by the law decree, because as we know, these are people with a very high prevalence of hepatitis C active infection. As you can see here, we catch by this strategy innates in 1,650 people, testing 34,000 people, more than 34,000 people. And here the positive for active infection is higher, is 54%, despite less than what is expected. And again, regarding, however, here the prevalence is exactly as it is reported in the literature. So it's decreased from 40% 2 or 3 or 4 years ago in 9% in all innates in Italy. And regarding the drug users, we see that unfortunately the coverage rates is only 30%, and the prevalence rates is 23%, which is lower, and it could be good because maybe it is due to antiviral therapy of this population. And however, the positivity for active infection is also lower than accepted. And however, doing the screening, conducting the screening in 71,000, more than 71, almost 72,000 people that are drug users, we detected more than 7,000 new infection by hepatitis C. This is only in 1 year of active screening by law decree in Italy. And this is my last slide that can address only the challenges on this experimental screening of general population. The dedicated fund end up at December 2023. So we need to know now what is going to happen with these funds for screening, which need to be extended because they are not used yet in all the Italian region. There are no strategies to increase the linkage to care because it's seen that somewhere we have the gap in the care cascade. The general practitioner, despite they are very need to be more involved because they are indicated, but they are not fully involved. Hospital opportunistic screening is implemented only in few regions. And as I said, there is a lack perception of risk in young population. And so this could be seen also by the low screening uptake in this population. So other shortage of healthcare personnel, or in addition, no dedicated strategies for most marginalized population, and the strategic communication need to be improved in order to improve also the results. I thank you for your attention.
Thank you much for that excellent overview. A lot of good areas to explore from that presentation from Loretta. We appreciate that. Let's move on to Pakistan, where we'll hear from Dr. Huma Qureshi as the Pakistan Hepatitis Focal Point, building on micro-elimination programs to reach national elimination. Huma.
So good afternoon, everyone. So that's the coalition slide. And this shows that, Pakistan has the highest hepatitis C burden in the world. For Hep B, we have about 14% population that has been diagnosed and about 5% have been put to treatment. And this 5% is obviously low, but then, we don't have the real clear indications of whom to treat. So we are waiting for the new guidelines so that we may start treating the larger population. For Hep C, about 30% of the population has been diagnosed, and the numbers who have been put to treatment is about 15%. And I guess this is again a bit lower because we now think that we have probably crossed about 22%. The Hep B prevalence is 1.1% and Hep C is 7.5%. New infections are 30,000 for B and about 110,000 for C. So this is again something very new, and this is a real-time data which we collected just last year. on about 25,000 people who were screened last year, and they were negative, and then we screened them again this year. And so only it's 0.1%, which comes to about 110,000. Previously, like it was put to Pakistan that we had 470,000 new infections. So this number has really gone down. So the AMRO region is very happy, and so is the global because the infections have really gone down. So that's a good news for all of us. So this is the decentralization of the care and the micro elimination that I'm going to share. So this is a project which was done with the government of Sindh, where I work in Sindh, along with an NGO called Negeban in the Civil Hospital Karachi, and then the Health Foundation, which is a CSO, and then WHO and the USAID. So this is like the map of Sindh, and there you see the red area, that's the place where the micro elimination was done. So this is the health minister actually selected the site, and she selected that site because of two reasons. Number one being that this was a flood affected area, and if you can see on the slide that there's flood, it was actually a video, but I don't want to, or maybe I don't know. So this is a video which shows that there were floods in that area, and the flood water was there for almost a year. So when we went there, there was already flood. we reached the sites, through water. And then this was a high prevalence district. So the minister really took us to task to see how we perform. So this is one of the taluka. Taluka is a smaller part of the district. So it's a small part of the district. So the population, the total population of this taluka, the area was 400,000. And out of this, we included all individuals who were more than 12 years of age. So the population to be screened, tested, and treated was 210,000. So we did the situation analysis first, and then undertook the stakeholders meeting with the local notables. For the task shifting, we used the lady health workers and the other health facility staff, and trained them in the rapid tests and the data collection, and also for providing treatment. And for the strengthening of the sites, there were 22 dispensaries and the rural health centers that they were the lowest of the low. And they were provided with the desktop computers and the supplies of the RDTs and the blood collection tubes. And the decentralization was done where the district hospital was equipped with the CBC, the AST, and the PCR machine, so that all the tests could be done there and then and passed on to the patients for further treatment. So the screening was done in 3 phases, and a 3-prong approach was used. In the first phase, which lasted for 4 months, we screened at 20 health facilities, which were basically dispensaries and rural health centers. But despite everything, we found that only 20% of the population came to receive the support from the screening support from the facility. Then in the next 2 months, we started the door-to-door screening using the lady health workers. And in Pakistan, each lady health worker has 1,000 houses assigned to her. So she can go around those houses and screen them. So we use the lady health workers. And within 2 months, we were able to reach 54% of the population. And then there were areas which were not covered by the lady health workers. So for these areas, we use the vaccinators and the community health workers. And with this, this was just a 1 month activity, and we were able to reach 18% of the population. So by task shifting and decentralization, as I told you, the lady health workers and the health staff was trained to do the finger stick test for both B and C. And then they entered the data in the tabs. And then reflex blood testing was done at the district hospital level. APRI was inbuilt in the tab. So once they put in the data, the APRI was calculated automatically. And then soft DACLA was supplied through the coordinator, who's obviously not a doctor, just a person from the health facility. And SVR was done after 12 weeks through a coordinator who brought these patients, because these were known patients, so he was able to bring them back for retesting. So 93% of the population we were able to access using this 3-prong approach. Anti-HCV prevalence was 2%, HBS prevalence was 1.5%. 92% of the population underwent anti-HCV positive population underwent the PCR testing, and the test was positive, or the PCR was shows a detected virus in 51% of the population. And this although appears low, but this is because almost 15 to 20% of the population has already been treated. So the PCR numbers would gradually go down. And of the people who are positive on the PCR, 79% have been started on treatment and 44% have completed the treatment. Rest are still on treatment till I analyze the data. So then this is not the only microelimination project that we have taken. There are quite a few others. I'll just very briefly tell you that there's an NGO called the Health Foundation. I'm the director of that. So they have screened about 600,000 population, which is testing and treating in Sindh province. And INGO MSF has screened, tested and treated 100,000 population in Karachi. WHO screened 100,000 population in Punjab. The JC Martin Foundation and then the NHEPs, this was 50,000 population in each of these, projects in Islamabad and in Malir. Then Abbott supported in 45,000 police workforce, which was screen tested and treated in Islamabad. Another Parsa Trust screened 30,000 population in Punjab. And this currently Welcome Trust is screening 25,000 population, and they're doing the reinfection, they're checking the reinfection rate and the incidence rate. So this is something very new that we're going to be sharing with you in the next few days. So in conclusions, microelimination is possible by task shifting and decentralization using the already available health staff at the grassroots level. A reflex blood testing reduces the chance of losing the patient. And with decentralization, when you have the tests which are available there and then within the facility in the district, then the tests are very quickly reached to the patient, and then it improves the trust of the patient on the health facility and the staff. And there is excellent compliance, so that once you start the treatment, it's rare that somebody doesn't take it because there are no side effects. And we know that the similar approach is used by most CSOs and NGOs who are working in Pakistan on the HCV elimination. So thank you very much.
Excellent, a lot going on in Pakistan, and that's just gives you one glimpse of that. We're going to go on to our last section of talks about looking at different ways of achieving equity. Three presentations here, starting with yours truly. Talk about the United States, then that will be followed by Indonesia and by Mexico. Okay, well, the slides have indicated otherwise. So we'll start with Carolyn Thomas, who's from Indonesia, the Peduli Haiti Bangsa Foundation, expanding access to hepatitis B and hepatitis C screening and treatment in prisons and HIV clinics.
Thanks, Jen. So yours truly, Caroline. Thanks for the opportunity. I hope you can see me. So my talk is on about expanding access to hepatitis B and C screening and treatment in prison and HIV clinics. I know that the topics that I'm going to take, we have some of you have been mentioning, and also I just want to reiterate the possibility of microelimination. This is just a little bit of the introduction. Yayasan Peduli Hati Bangsa is a non-profit organization by and for people living with and affected by viral hepatitis and HIV. So our goal is to raise awareness, educate, and also improve access for the general public as well as the key population, of course, regarding diagnosis and treatment options available in Indonesia. Some of our main activities, including advocacy, community education, community-based study, community service, and community-based screening and support. Just a little bit of the background. We don't have recent data, so we are having I'm using the latest data was which was available in 2013. Recently, we're doing the basic health research, another basic health research, but the result hasn't been published. So for Indonesian, we have 7.1%. The prevalence is 7.1% of the total population of Indonesia is living with chronic hepatitis B. So if you can see, I have the map. We are now in Netherlands, so I'm using the map of Netherlands. So it's 7.5% of the total Indonesian population, equals to the whole population of Netherlands plus 3 million. So that's how much. So it means that if you're not treating the people who are living with hepatitis B, it means that we are literally killing the whole population of Netherlands plus 3 million, another 3 million people. And for hepatitis C, that's around 1.1% of the Indonesian population. So it approximately twice the population of Amsterdam. So the whole population of Amsterdam times 2. So the question is, why expanding access and micro-eliminate? This because to achieve like the elimination goals, of course, will require full-scale resources, but breaking it down to a larger elimination goals into a smaller and achievable goals will provide a less intimidating goals and resources. If for those who have children, if you give them a whole plate, they will reject it. So if just divided by small plates or a small, use a small spoon and feed them. It will create like a small victories and small successes for them. So that's exactly how the logic is. These are some of the timeline of the community-based initiative. We have plenty, but I will just focus on this. We started in 2019, 2020. We had HIV Hep C screening and treatment in Jakarta prison. And in 2022, we started also in Bali and West Java prison. 2023, we had HBV vaccination for orphan children and also training of healthcare workers to micro-eliminate. Actually, this is to triple eliminate HIV, Hep B, and also syphilis among mother to child. And in the plan for 2024 is rapid vaccination schedule for key population. There are several initiatives, as I told you before. In Jakarta, there are 7 prisons. Bali, there are 2 prisons involved. In West Java, we have 3 prisons. And all inmates were screened for hepatitis C and HIV, except when they opt out. Data specific for Jakarta will be provided in the next slide. So this is the result of the hepatitis C screening in 7 correctional facilities in Jakarta. In total, we have screened around 16,063 people, and the number of anti-HCV positive is 6.1%. I think it is similar to Portugal and Italy, I guess. Yeah. And also 100% of them were referred for viral load confirmation, and around 89% had hepatitis C viral load detected, means that they are having a chronic hepatitis C infection. Around 57% started treatment. At that time, this is when the COVID started. So at that time, we had no logistics for the medicine. That's why the number was very low for number of people starting treatment. However, out of that number, around 98.8%, almost 99% completed treatment, and again, very low number of people tested for SVR12 because of the non-availability of the logistics. But out of that number, 100% achieved SVR12. As for the HIV status and history of being IDU, we cross-tabulated the data, and we found that for those who had reported history of being an IDU, around 33% of them were screened positive for hepatitis C. So this is this was expected because that's one of the risk factor. But among those who had reported HIV positive, around 43.9% of them were screened also positive for hepatitis C. So the takeaway message is microelimination, of course, requires adequate resources. This by means in terms of funding resources, but also in terms of human resources, and also logistics. This is very important because since we don't have any logistics in terms of the medicine and also for the viral load, that's why there are some gaps that we need to fill in, and it was not available because of the unavailability of the logistics. And then there's supposed to be a comma after the logistics, means that is the skill, and then training and also commitment from all five parties in this. I'm taking the pentahelix structure, so all government, business, academic, community, and also the media should be involved in the microelimination. And the effort to microeliminate is a very well targeted and will build national momentum by producing small achievements that inspire more ambitious efforts. So we hope that this sharing could, could, what do you call that? Motivate, motivate the future actions. This is just a little bit of the story for hepatitis B vaccination for orphan children. Since we have very limited funding, we started vaccinating around 50 children. There are orphan children who live in a disaster-prone area. But then for the next year plans, we had actually learned from one study done in India, actually in one state in India. This was done also by an NGO. It's called Community Network Empowerment, in short, CONE. They vaccinated around 677 people who inject drugs following the rapid regimen schedule, which was recommended by WHO for 0, 7, and 21 days. This was done because the compliance rate for 0, 1, 6 monkey population is very challenging. During their study, they found out that around 86% develop immunity with anti-HBs titers with more than 10 MIU per ml. So our plan for next year is to do a similar study on the use of HBV rapid regimen vaccination schedule for key population if we have the resources. Okay, I think that's the end of my presentation. Thank you. I think 5 minutes.
Excellent. Fantastic. Yeah. We will now hear from Dr. Alexei de la Torre Rosas from the Ministry of Health of Mexico, achieving microelimination of persons living with HIV.
Thank
Alexei.
you.
Thank you.
So thank you very much. And we're going to give a brief presentation about what we've been doing to eliminate the co-infection of hepatitis C in people living with HIV. So in 2019, we decided that it was time to change the approach of the HIV program towards an HIV, hepatitis, and STI program. But of course, if you want to have a person and community-led approach, you need to involve them. So people were involved since the beginning, and we need to address and understand what are the barriers and the challenges, including social determinants. You cannot think about eliminating hepatitis C or B if you don't think about mental health, harm reduction, sexual and reproductive health, but also infection control, prevention, migrant health care, people living in jails, and other areas. So by the end of 2019, the pillars for the elimination of hepatitis C in Mexico were defined, and we have 4 main pillars. The first one is to have universal free, patients paying nothing about their care, access to testing and treatment, unified program across all care systems and provided. Mexico is a very complex system. And to have that information, we decided that it was important to have a unified registry. Also to have a primary healthcare approach, health literacy for both healthcare workers and population, including innovation and research, and strategies focused on high-risk groups, including harm reductions. And I want to highlight the year 2019, and it's the end of 2019 when we started this. So the COVID pandemic started in 2020 with our programs, and we decided that hepatitis C could not wait, but also we needed to be pragmatic. So a low-hanging fruit approach was required to start. And we defined that we needed to start with people living with HIV. The reasons were that they were a group with high prevalence, the community engagement and leadership is there. There's a lot of health literacy among people living with HIV and as well as healthcare providers. There's a chronic condition that it has a very good follow-up, and there's a captive population. There are already a lot of programs about adherence to treatment, and there's a primary healthcare approach and healthcare workers trained to register high impact and cost interventions, but also addressing syndemics, program integration, resource optimizations for HIV, hepatitis, STIs, tuberculosis, and addictions. So as you can see in these graphs, in 2019, we had nothing but the analysis of the impact, and considering that liver disease is one of the leading causes of mortality of the country, and hepatitis C is the main cause of liver transplant, we started in 2020. So with all the policies, and then after HIV, we started with the rest high-risk populations, and recently with general population. So we needed to start with primary healthcare units. So in 2019, you can see less than 50 green dots, and those were the units that were available in the country to treat patients with hepatitis C. By 2020, we increased those numbers more than 150 units during the pandemic. And by 2023, we're very happy because we have more than 1,500 primary healthcare units for diagnosis and treatment of hepatitis C, as well as secondary and third level units. And since the beginning, we decided that it was important to have a data-driven program and public benchmarking. So we have in on the official website public data and how each of the sites are doing in terms of testing and allocating the resources. And for people living with HIV without social security, we have tested more than 117 people, and of those, more than 3,000 have been diagnosed with hepatitis C and of course treated and cured. And since 2021, we started to put how this was in terms of the regions. We have 32 different states, and you can see how the colors actually have increased the numbers of greens, which means that they have not only do the standardized treatment, but also register. That's very important because sometimes people, it's difficult for them to register, and by putting this in a public benchmarking, we have the input of that information, and that's been very useful for the different states to advance. Also to have a person-centered registry. We are able to track every single minute if we want, how many tests and people are being treated, and we can have that information based by any units, etc., and risk factors as well. And the economic analysis, which has been amazing in terms of being able to focus on the next states and where to focus, and international comparisons and improvements. Of course, the NHEP profiles have been amazing. In the first one, we actually identified some gaps of hepatitis B, and we have improved our guidelines in order to include that as well. We have online courses, including 70 clinical leads for telementoring, and over the last years, we have been able to enroll more than 500,000 healthcare workers across the country, with more than 300,000 approving the course. And of course, having the telementoring strategy has been essential for people to expand their capacities and create new leaders. So of course, we could not wait during the COVID pandemic, but that was not just one event. We have a lot of disasters, wars, and other areas that if we don't have resilient systems, we will not be able to achieve the goals. So this is just an example, a recent example. In October, a hurricane category 5 hit Acapulco, Guerrero, and basically destroyed the whole region. And what we've been able to do since the day after the hurricane hit the region was to create those resilient systems and to be able to have a person-centered approach with hepatitis, HIV, STIs, and tuberculosis as well, and being able to expand the capacities and to make sure that even in the worst disaster, your capacities are maintained. Thank you.
Very much. I know we're a little over time, but I'll give a few perspectives from the United States regarding our policy development and how it relates to destigmatizing hepatitis C. So hopefully, are we in the right place? Yeah. Okay. This is a little bit of a glimpse of our profile. We have an estimated 2.4 million people living with hepatitis C. We have about an estimated almost 67,000 new infections every year. Getting a little bit more detail on that in a moment. And about 15,000 deaths from hepatitis C, which we're going to be focused on the testing policies and how that has evolved over time. I guess about 10 to 12 years ago, this was really the profile of the epidemiology of hepatitis C, where you had a large prevalence among a certain age population because of the risk of exposures earlier in their lives because of unsafe healthcare, unscreened blood, and injection drug use in the community. And it was, when you did now serial surveys, this sort of high prevalence bump was moving through time, indicating lower incidence in younger populations. And it fit very well with what was called in the United States the baby boomer population of people born between 1945 and 1965. And indeed, 2 out of every 3 people with hepatitis C about 12 to 15 years ago were in this so-called birth cohort. And when you looked at them, their disease state, about 60%, I'm sorry, about 50% already had moderate to severe liver disease, and the deaths were increasing over time, and indeed becoming the leading cause of death among diseases that were reported on a regular basis to CDC. So we had a real strong epidemiologic case for focusing on this population. So we moved the country from a risk-based approach to testing to a general population-based approach to testing with this birth cohort strategy. And this gives you some more additional reasons for that. And I had to say, we had to change the culture even within the US CDC, which really regarded, many within the US CDC regarded there are 2 types of people with hepatitis C: people who told you they were a drug user and those that did not tell you, they were a drug user. And we really had to change that culture, that indeed there were other people that had other risk, and you were unnecessarily stigmatizing the epidemic. And that this birth cohort approach moved it more to a general health benefit of knowing your status. And obviously that was greatly aided by the licensure of highly effective all oral direct acting agents. See, did that change? No. And So we then were able to embark on a national awareness campaign, highlighting the value of knowing your status, but if you were born in these years, keeping in mind people were in this age group and they were getting other preventive services at this stage in their lives: breast cancer screening, colon cancer, blood pressure, diabetes, etc. So it fits very well with this preventive set of care that you're already receiving. And obviously it's easier to put this on a billboard than, are you an injection drug user? Please go get tested. So this was a very well received public awareness campaign. And as a result, more people did indeed get treated. The prevalence has declined. And we are on track to meeting the interim targets for mortality reductions from hepatitis C that were set by WHO. Now, what's changed is that we now have 2 bumps. We have had large increases in HCV incidence among younger people because of an explosion of drug use, particularly opioids. And that's been associated with increasing numbers of people who are injecting those opioids, leading to high rates of HCV infection. So in 2020, CDC moved to a recommendation that all adults, including younger adults, need to be tested at least once for hepatitis C to reflect this changing epidemiology within the country, but still trying to do the testing recommendation in a way that's not overtly stigmatizing by immediately associating that with a particular risk that or social practice that some may view as undesirable and stigmatizing. And again, we had to make the cost effectiveness case for that. It was adopted as a routine preventive service, meaning that patients can get this at no cost now as part of their primary care. So that's now the recommendation, and we are looking forward to data to see how broadly that is being adopted, particularly as the country emerges from COVID-19. But what challenge you have here with the general population recommendation, while still having a concentrated population of people at highest risk because of injection drug use, is to how to balance your testing programs to have that general message to avoid destigmatization and promote broad adoption throughout the health system, while still focusing your precious public health resources on the sites that are providing services for people who inject drugs. And we have a long way to go in improving that prevention services in the United States, with too few needle and syringe exchange programs for people who inject drugs, and too few drug treatment facilities providing HCV testing and treatment services. So while we promote a general population screening, we still have to begin to focus our resources on the populations at highest risk. As part of that effort, we have a proposal from President Biden to develop a National Hepatitis C Elimination Program. This is the first real effort in this regard, with a budget request of $13 billion to Congress as part of the president's budget. And we have Dr. Francis Collins, the former director of the US NIH, that's leading this effort. And he just had an editorial in the New York Times yesterday making a strong case for why the US needs a National Hepatitis C Elimination Program. And he's acting more and more like a civil society organization as he talks about his brother-in-law who died of hepatitis C and how he doesn't want that to happen to anyone else in the country. And so he's a very powerful representative of what needs to happen in the United States. And he's really doing this in a way to promote this equity by saying that no one should be dying of hepatitis C any longer, and let's do something as a country to make that happen. And that's where we are. Thank you. I want to thank the last speaker for really a great finale. But I want to thank everybody. That was a wealth of information in a very, very short period of time. I know there was a lot more we could explore about each and every one of those, but I think we all have a deeper appreciation of what's going on. And for me, when I hear these kinds of snapshots, it just makes me even more committed to hepatitis elimination, because there's a lot of positive movement toward hepatitis elimination, and it's just evident just in the last 3 to 4 hours that we've been together. And so it's not a question of can we eliminate hepatitis. We are eliminating hepatitis. It's just a question of how quickly are we going to get to these targets. And the more we work together, get more capacity, bring more partners to the table, the better, the faster we can get this done. But we are working toward these goals, and we will be successful. It's just a question of when. So I appreciate that. The webinar materials, again, will be available on globalhep.org. All the presentation slides, the video. We'll develop a synthesis report from this. And that's where you'll be, also these National Hepatitis Elimination Profiles are also available there. And for all of you in the room and for the web audience, please sign up for our newsletter so you can get stay up to date on what the coalition is up to. So I think for that, we will sign off on the webinar. And thank you all for your time. Let's give ourselves a round of applause.